I would like to highlight the clinical part. The clinical part with me. Are you with me?
Yes.
Hello. Okay. I would like on these lectures to cover part of the parasitology, part of the entomology, which is study of flies and the vector, and part of the pathology as well. It's not going to be comprehensive for all of them, but at least we will touch on the important parts of each disease so that this opens a door for all the students to read more. Okay, I based the lectures on cases. The first case will come to you, the case will come to you soon after I finish the lecture. This is a new case. In 2-3 days, I'll send some results of the investigations, okay? And on the third message, I will also send the answers to the different questions. So by the time when you join me in the next lecture or subsequent lecture, then at least you will have had the diagnosis and some comments on the treatment, because this is an open book, and I'd like to concentrate on the case and how we can lead from the case to the disease. Okay, is that okay now? And I encourage you to look into the case. The case wouldn't take more than 7 minutes to look at. Try to think about it. If you have a chance to write down what you think, it will be better, because it will fix on your mind. And then think about it as you are in the room, as you are on the road, etc. Apart from this, we are running the trivia. The trivia meaning small or miniature examination or miniature test, which has been, we formulated the questions and send it to Juvi. Juvi will send it to you, and she will give an answer to the questions, because these are corrected by computer. Okay, today we are going to go through the case of Hajja Amna Mukhtar, who resides in Doka. Doka in near Gadarif, and this is eastern part of Sudan. And here are penny drops. When we are talking about tropical disease, always think about geographical location, and we'll come to that. So Amna had chronic fever, all right, because the fever is extended beyond 7 days. And during these 7-10 days, she was fairly okay. She did not bring herself to the hospital, and the hospital, okay, she didn't bring herself to the hospital, and she needed a lot other investigations as inpatient. So it's a chronic fever. This is in contrast to acute fevers like malaria, which once you get a fever today, you get anorexic, vomiting, aches and pains, sweating, and you can't continue. The only place you go to is the health center or the hospital. But this Amna has been going on, and we noticed that she was eating okay. And in this case, which is no doubt, there is no secret about it, is visceral leishmaniasis. Okay, it's appetite was okay, but then very soon she became anorexic. She lost weight. Okay, she deteriorated, and she became anemic and weak, with pain in the left hypochondrium, which later on it was revealed to be a big spleen. Okay, so on examination she was pale, all right, and she had these lymph nodes. And here you will note that there is epitrochlear. Epitrochlear is over here, okay, epitrochlear. And this is maybe an indication of visceral leishmaniasis, epitrochlear, so, and cervical. Okay, so the spleen is big and the liver is big. The liver is not as big as the spleen, but it's at least 2 centimeters below the costal margin. The rest of the examination was okay. So this is a lady who had chronic fever, who had lethargy, weakness, constitutional symptoms, loss of appetite, loss of weight. She has lymphadenopathy, pallor, and huge spleen or enlarged spleen, which is a case of visceral leishmaniasis. So, what are the other possibilities? The other possibility is certainly is brucellosis. Brucellosis is a bacterial disease, bacilli, which may be bacilli of the Brucella melitensis, which is in cow, sheep, and cattle. It gives fever, I guess, chronic fever, no doubt about that. She can give an enlarged spleen, particularly hepatosplenomegaly, but the spleen will be large. And in about 10% of cases, they give lymphadenopathy. So this is another differential diagnosis which matches with the rural area of this Amna. Okay, she's living in a rural area, so she is exposed to raw milk and boiled milk, and she's exposed to animals which may carry the Brucella bacterium. So that is another possibility, and I think it is the second possibility. In contrast, obviously, visceral leishmaniasis can have lymphadenopathy up to 65% of patients. Not all patients with visceral leishmaniasis have lymphadenopathy. But the beauty of lymphadenopathy, if there is any beauty about physical science, this will offer you a site for puncture and aspiration to find the organism, because lymph nodes are superficial, are not painful, and easy. There is danger from taking a multiple aspirate from the lymph node for diagnosis. So if you have lymph nodes, you are slightly lucky in catching the diagnosis. So this is second, brucella. The third is clearly is not malaria. Malaria has to be excluded, but this is not the picture of malaria. Okay, so it's acute fever with very patient had 7 days, which is off her. She's slightly off color, but otherwise, this is a chronic fever, not like malaria. And I think later on we have to exclude malaria by repeated blood films or 2 blood films by Gimza stain. A third possibility, which is real, is tuberculosis. Tuberculosis is a mimic for diseases. Wherever you have a chronic fever, you have to think of tuberculosis. And tuberculosis may only show with a fever. If you have tuberculous intestinal disease or tuberculous lymphadenopathy of the para-aortic or para-aortic lymph nodes, then, or even if you have tuberculosis of the spinal cord, all this will give you fever. Nothing apparent on the examination. So maybe the chest is normal. So the fever which is hidden is, you have to think of tuberculosis, and tuberculosis is often associated with sweats, but particularly with lymph nodes. Lymph nodes can be a feature of chronic tuberculosis, especially cervical lymph nodes, and these can grow big, they can liquefy, they can cavitate, they can open in the cervical region, discharging pus, and a fistula, which is notably difficult to treat, difficult to close, okay, with normal antibiotics, which is another indication of tuberculosis. So tuberculosis has to be thought of all the time, and since we have a superficial lymph nodes, then that is easy aspiration, and even you can take a lymph node for biopsy, proper biopsy. The other differential diagnosis may be in this area, may be in other areas, non-tropical, is leukemias. And particularly here, we are looking for lymphocytic leukemia, although the age is younger for lymphocytic leukemia, and chronic myeloid leukemia. You may argue that chronic myeloid leukemia will not have lymph nodes. That's not true, because some of the chronic myeloid patients will have some lymph nodes. Obviously, both of the chronic myeloid and chronic lymphocytic would have hepatosplenomegaly, particularly spleen. So that is another possibility, very easy to exclude. The by white count. You with me? There is a hello.
Yes. Back,
Well,
Prof.
okay. So the white count is very easy, very simple. You can have it at bedside, and if the white count is normal or low, then that will put the diagnosis in one category. If it is highish, okay, then it is. If it is the normal is 4, then if it is about 15 or 18 or 20, that is high, which indicate the infection. But if it is in hundreds, thousands, or 10,000s, then this is leukemia. So it's very easy. And for lymphocytes, very easy to see the lymphocytes, which may be mature lymphocytes in chronic lymphocytic leukemia. And when there is fever, you always think about an acute phase or the chronic type of the leukemia. So this is apart from the diagnosis or differential diagnosis. And in a matter of fact, if we have a case of brucellosis, then we work out the same differential diagnosis. So we may not need to repeat it if we catch a patient with brucellosis. Okay, we gave you the results, and the results were hemoglobin was low, 6.8 gram per deciliter. The normal is 12 to 16. Platelets were low, 98, 10 to the 9 per liter. The normal is 150, so it's low, and important to remember the platelets when we are dealing with diagnosis. Okay, hemoglobin is low. Okay, so this is pancytopenia. All the components of the blood are low. So the anemia is not a diagnosis. If I tell you that this is a case of anemia, it's not a diagnosis. Anemia is an indication of low hemoglobin. If we talk about anemia, we talk about, say, iron deficiency anemia due to blood loss, or pernicious anemia due to folic acid deficiency. So don't give a diagnosis of anemia, because anemia is just a physical sign, pallor, and low hemoglobin. So then in chronic infection like this, the anemia is usually of normochromic normocytic type, normocytic type, and this is what is being here seen in this case. White count is low. There are 3 fevers which will lead to low white count. The first one is semi-acute or acute, which is a typhoid fever, will give you a low white count. Visceral leishmaniasis or calaza will give you a low white count. And brucellosis. These are the 3 fevers which will give you low white count. Other fevers give you highish or high white count. So pancytopenia, meaning that the reticuloendothelial system has been affected. And this is typically the case of AMNA, because the parasite, the Leishman-Donovan body, which is the protozoal parasite, it's a unicellular parasite, inhabits the reticuloendothelial system or bone marrow producing cells, the macrophages, the bone marrow, in the spleen, in partially the lymph nodes. So this is a pancytopenia, and we have seen the reasons for this pancytopenia. So what are the investigations which we will do? Okay, if you pursue things like blood film for malaria will be out of the place because it's been negative repeatedly. You can have ICT of malaria, which is again should be negative. Then the lymph nodes should be examined for presence or absence of Leishman-Donovan body, Leishman LDB, Leishman-Donovan body. And Leishman is a scientist or a doctor, and Donovan is another doctor. I will tell you about it. And the name is being coined by a physician called Ross to say Leishman from Leishman and Donovan from Donovan, and the body. The bodies are small, oval, or rounded structures, which are found in heavily in the splenic aspirate, but also it can be found in the lymph nodes. It can also be found in the bone marrow. So why don't we rush to the spleen and get aspirate, since the presence of the Donovan body in 95% will be there. The only precaution is that splenic puncture is not an easy thing. It needs care. It needs a hospital with facilities of blood transfusion, etc. So this is why we go by first lymph nodes, aspirate. We can aspirate the lymph node 2, 3, 4 times, okay, and then Gims the stain. And if you find the Leishman Donovan body, then you are safe, and the diagnosis is reached. So this is why, because the lymph is not dangerous. The second is bone marrow. But obviously, bone marrow needs somebody who can stain it and can look into the LD bodies. Thirdly, if we are really stuck and we are in good hospital, then a puncture of the spleen. And if you want to puncture spleen or liver, for fear of internal bleeding, you have to check on the platelets, okay, and the hemoglobin. Usually, we supplement hemoglobin or infuse blood transfusion and correct the platelets if possible before the puncturing or even before the biopsy of the liver. So these are the precautions. All right, there are serological tests which can be achieved, and the serological tests are many. I gave you in the last paper is R, small r, capital K39, RK39 antibodies, and this is what we call rapid diagnostic test. It's an immunochromatographic test, immunochromatographic test, using antibodies in the visceral leishmaniasis, which is called RK39. So this can be positive, and it yields positivities. This is serology, and there is another serology which takes time, it's longer. It's called DAT, capital D, capital A, T is DAT, which is direct agglutination test. And these tests, if positive, we start treatment. But if they are negative, which can be negative, then we have to revert to more investigations like lymph nodes or bone marrow. Why do we insist on reaching a diagnosis of this leishmaniasis to the end, seeing the LD bodies, which are small, rounded structures? The answer is because the treatment is prolonged. It goes up to 30 days, and relapses can occur. So if you are not sure about the diagnosis, then if there is failure of treatment, you will not be sure about if your diagnosis was not correct, the drug is not responsive. So it's important to get a final diagnosis. Okay, the Kalazar is a Hindi name. Kalazar is Hindi name, and it is called black fever. The black fever, or the fever which is give black skin, mainly face and hands, and this appears in the Indians because they are fair colored. At least some of them are fair colored, and it appears that this is blackish color of the hands, arms, and face. This is why Kalazar is named as the black fever. Okay, so the diagnosis of visceral leishmaniasis is made, and then treatment has to be given. The disease is fatal. If you don't treat it, it's fatal. It's fatal. It kills patients, and the treatment is still, although good but not satisfactory. It's good but not satisfactory. You remember in the first lecture, I said the greatest improvement in treatment of tropical diseases is finding a drug which is orally given, which is very devoid of side effects, and which can be given once. Okay, unfortunately, we have not reached that in visceral leishmaniasis. Okay, the treatment is mainly antimonies, and you remember antimonies are all drugs. Even schistosomiasis, bilharzia, used to be treated by antimony tartrate, which is very toxic. But in here, we are using a pentavalent antimony, that is trivalent of schistosomiasis. It's a pentavalent antimony stibogluconate, stibogluconate, okay, or pentastam, sodium stibogluconate, okay, it's pentastam. The dose is 20 milligrams per kilogram body weight, and the treatment goes intravenously in a drip form, in an infusion form. Don't give it directly into the vein, otherwise you'll cause cardiac arrest. So it has to be diluted. The amount per day, it is daily, has to be mixed in 500 saline solutions, all right, and then given over at least 4 or 5 hours. Because this way we are diluting the antimony in the blood, okay, gradually. There are side effects for the antimonies, and the precautions. Before treatment, you have to correct the anemia. You have to correct the anemia because you need somebody who is good hemoglobin to tolerate the antimonies. Secondly, you have to give enough nutrition, raise the level of nutrients in the body. And by the way, this had angular stomatitis, indicating avitaminosis. Okay, so correct the anemia, okay, and then do an ECG, because one of the problems of sodium antimony gluconate or sodium stibogluconate, which is pentastam, is cardiac arrhythmia. So this is important. If the ECG is normal, then you can proceed. If the ECG is not normal, then there are other alternative drugs. We used to give 14 days continuously for visceral leishmaniasis, but unfortunately, we found that these days are not enough. We went up to 21 days, and now we are up to 28 or 30 days. So this is an indication of partial resistance to sodium stibogluconate. So there is partial resistance. Okay, are there relapses? Yes, the answer is yes. You can have some relapses. You can repeat the course as necessary. So that is stibogluconate. Let me finish with the other drugs. The other drugs is pentamidine. Pentamidine is another antimonial, okay, but it's not used very often. And there is amphotericin B. Amphotericin B. The amphotericin is antifungal, but here we are putting it in a solution of lipid solution. This is why we call liposomal amphotericin B. Lipo from lipid, liposomal is molecules of lipid in amphotericin there. It's been put and it's called liposome. Liposome. This is another drug which can be given intravenously. Pentamidine is also given parenterally, so we are still on the parenteral side. And there is a drug recently called miltefosine. Miltefosine, miltefosine, miltefosine. And this is given orally in a dose of 100 milligrams per kilogram body weight, given over 30 days. The beauty about it is given orally. The drawback is this drug is an abortifacient. It can cause abortion, and it's a teratogenic drug. So we have a difficulty in giving them to women, especially young fertile women who may wish to have babies. They may abort them, and if not, they may have teratogenic effects. So that is a major limitation especially in rural areas. Women don't know if they are pregnant or not till the tummy becomes big enough to be seen. So it's something which we have to bear in mind. And the worst thing is to treat Kalaza and then have a baby with congenital abnormality who will stick to you for the rest of your life. So these are the drugs. So sodium stibogluconate, which is pentastam, which is the drug of choice up to now, given on prolonged period, 20 milligrams per kilogram body weight for 28 days. And then we have the amphotericin B, which is liposome put in lipids, and then this is the dose is given over 30 days. Dose is 100 for 30 days, daily for 30 days. And then we have miltefosine for, again, miltefosine for 100 for 30 days. Okay. There are other new drugs which are coming because up to now, physicians are not satisfied with the dose. But up to now, pentastam is the drug of choice. Having said that, you should revise the pentastam. You should revise the side effects of that drug. You know, it's a very important drug, and many patients, or most all patients, will respond. What are the criteria of response to pentastam? The criteria number one is the fever will subside in 7 days. Number two is the patient will start eating. So the anorexia will be subsiding, and the patient will start weighing, increasing the weight. Okay? And then thirdly, the spleen becomes smaller. In time when we were house officers and registrars, we used to line the level of the lower edge of the spleen gradually to see how the spleen recedes with continuous treatment of pentastam. Lymph nodes will disappear and the patient becomes well. So that is as far as the visceral leishmaniasis. Leishman-Donovan body, because there are other parasites of the Leishman type, which is Leishmania tropica and Leishmania ethiopica. Leishmania ethiopica. And then there are other forms, which infantum, Leishmania infantum, in other cases. So we have not talked about other forms of leishmaniasis, which is either dermal leishmaniasis or mucocutaneous leishmaniasis or visceral leishmaniasis. But there is a syndrome which follows treatment of Kala-Azar, which is called post-Kala-Azar dermal leishmaniasis. Post-Kala-Azar dermal leishmaniasis. And this is completely separate from dermal leishmaniasis, all right? Because the parasite is different. And here we are dealing with a recurrence, almost a recurrence in a different form. It's not recurrence of fever, ill, anorexia, but here the recurrence of the appearance of the parasite on the skin. And the skin becomes nodular, slightly nodular, and pale. And if you just take a scraping of the skin, then you get a lot of LD bodies. So here the danger is the patient will not feel ill. He goes around and the vector will catch a lot of LD bodies from that patient and spread the disease. So this is post-Kala-Azar dermal leishmaniasis. And here treatment is prolonged, even more prolonged than in Kala-Azar. So remember, post-Kala-Azar visceral leishmaniasis. Post-Kala-Azar leishmaniasis, this occurs after a month, 2 months, sometimes years after treatment of Kala-Azar, you get post-Kala-Azar visceral leishmaniasis. Okay, the other forms which we'll deal with later. I don't want to confuse you with a lot of confusions, but the divisions, the big divisions, is the visceral leishmaniasis. When I talk about visceral, meaning that the inside, with systemic involvement or systemic symptoms. Okay, visceral. When I talk about dermal, like nodules or ulcers, this is dermal leishmaniasis, and the patient is fairly well, no fever, appetite is good, it goes around, but only the skin problem. Okay, and even this, the dermal one, can heal spontaneously, but leaves a lot of scars. And if you go to areas where this is common, you can find a lot of patients with scars on the face due to dermal leishmaniasis. Okay, and then there is spondia or mucocutaneous leishmaniasis. Mucocutaneous leishmaniasis, and this is caused by Leishmania infanta, and it is described heavily from Sudan, okay, by Professor Ahmed Mohamed Al Hassan. And this is very disfiguring because it involves the mucosa of the pharynx, of the mouth, of the nose, and then it causes a lot of uh, ulcerations, very dirty ulcer, like a tumorous ulcer, and then the patient may heal, but it will remain with disfigurement because the parasite has eaten out the tissues, and this is cannot be repaired. So you have three types: the visceral leishmaniasis, and we have the dermal leishmaniasis, and we have the mucocutaneous leishmaniasis. The post-Calazar is under visceral leishmaniasis. Okay, so this is about the disease. So where do we find this disease? Almost 95% of all patients in the world are in 5 countries: Sudan, South Sudan, Ethiopia, Brazil, and India. So these are the countries where most of the research is coming from. And to my knowledge, the biggest volume of research in visceral leishmaniasis came from Sudan, particularly Professor Ahmed Mohamed Al Hassan, rahmatullah alayh. Okay, so it's a parasitic disease. The parasite is a protozoa. It's a single cell protozoa, and it lives in the reticuloendothelial tissue, macrophages of the reticuloendothelial tissue, wherever it is, either in the bone marrow, in the spleen, partially in the liver, and in the lymph nodes. These are where this parasite hides itself and multiply into these cells of the macrophages. All right, it is a vector disease. It's a vector disease which is conveyed from one patient to another patient, or from one patient to an animal, which acts as a reservoir, to a patient. So in a sense, this is a zoonotic disease, okay? So these parasites, the small ones, it's 2 to 3 micrograms, micromil, micrometer, yes, micrometer, 1 in a million of the centimeter. It's very small. And these are found in the. Okay, there are 2 forms of this parasite in parasitology. The first one is what we find in the human being. It's a mastigoid. And I think the last page, which I sent to you, has written these words, just to make sure that you've seen it. So amastigoids. Okay, this is the form which you find in human. And there is promastigoids. And the promastigoids is in the fly. And in the fly, the parasite divides, okay, and matures, okay, into, it sucks the mastigoids from the human, mature it in the tissue of the fly, and then inject it back into the human in the form of promastigoids. And the promastigoids goes into the reticuloendothelial tissue and becomes and erupts in the body as amastigoids. So the form in flies is promastigoids, and the form in human is the amastigoids. This is important because then we can divide the cycle into the vector side, and into the human side. And each part of the mastigoids, promastigoids, have certain characteristics which may help us in devising drugs. So it's the fly is a tiny one. Okay, it's a yellowish brownish fly, which is called Philobottomus papatasi. Philobottomus, or sandfly. يقول لك الذبابة الرملية. I don't know where the name came from, but it is not in the desert. It is usually in the savanna region. Okay, it's a lazy parasite. It's a lazy vector. It can't fly more than 2 meters above the ground, and it lives in refuse sewage system, disposal system. In the forest, if you have a cotton soil, you get cracks in the soil, and they live inside there. They feed from the rubbish which is there. It's a fly which does not um, travel too long, and it doesn't travel too high. This is why you find it in where it breeds. Okay, it just goes to the human, and what goes to the human is the female. The female eats on the blood, not because it wants a diet. It is because the blood is needed for multiplication of the eggs of the parasite, and this is for all insects, even the Anopheles mosquito, which is for malaria. Again, the one which transmits the disease and the parasite is the female. The male survives on flowers, on the juice of the flowers, and on plants. But the female, needing blood to mature the eggs, then it sucks blood. During this sucking blood, it gets out the amastigoids here, and then develop it and bring back the promastigoids. So it's the female fly which does the harm and the major harm, because it needed blood for development of the eggs. So there is a reservoir. And the reservoir is in certain countries, different from other countries. It can be fox, where foxes are around. But in Sudan, it is a rodents. It's a rodents, like a jigger, الفئران الكبار دي. Okay? So this is a reservoir. A reservoir is an animal which harbors the disease, okay, keeps the cycle going, because it doesn't the animal, so it survives and becomes a reservoir. Okay, so it's a zoonotic disease. The vector can travel from one human to another direct, or it can go to an animal, and the animal, when bitten, can give the parasite, and then it can go to the healthy human. So this is the cycle. And this is important in entomology, because if you want to combat the disease, or if you want to cut the cycle, you have to know exactly where the cycle goes and from where to where, and what is the weak point in the cycle. Is it the reservoir? You eliminate the reservoir. Is it the vector? You eliminate the vector. Or is it the patient? You treat the patient. So this is the way forward with entomological aspects. Visceral leishmaniasis generally has a good historical story. It's in 1908 or 1903, a chap or a captain in the army, in the British Army in India, called William Leishman. And he did a postmortem on a patient who died with chronic fever. Okay, and in the spleen, he sucked the spleen, and he stained the spleen, and he found these small 2 to 3 micrometers bodies, and he called it's a cellular, and he found this is very strange bodies, and in a patient who died with chronic fever, thought to be malaria. Okay, he published that, and 2 years later, a chap called Charles Donovan, in England, a soldier from India who has been invalidated because of illness was brought back to England, and there he died. And in post-mortem, this Donovan had a smear from the spleen, and the smear showed the same bodies like what Leishman has in Bengal of India. So they discovered the same parasite, almost at the same time, with 2 years difference. And Ross is a very big tropicalist. He described a lot of malaria, mosquitoes, and else. He named parasite of Kala-Azar by the two names. He said, this is a Leishman Donovan bodies. So this is now we know it, LD bodies from Leishman, William Leishman, and Captain Charles Donovan. Okay, so it's the Leishman Donovan. I'm interested in this because we have to keep and we have to innovate ourselves about these observations. Research is about observations. So these people, there is nothing which differentiate people apart from the brain. Okay, the rest of it, I mean, we don't care if he's a Christian, Jew, whatever. If you can find the right information and the right innovative approach. So these two people are great because they discovered that in 1903, 1905. But almost 100 years later, in Tunisia, this is Tunis, somebody discovered that there is a reservoir, and there it was a dog. Okay, so, and that is where the cycle completed itself when we knew the reservoir. Okay, so now from human to the vector, which is the fly, okay, to the Phlebotomus papataceae, then it goes into the animal, which may be the rodents or the dog, and then comes back to the human, okay, putting the parasite inside, and then the body takes it out, okay, Okay, so are there parasites in the blood? Because that will be easy, to take it and do Gim's stain and see the parasite. The answer is no. Very rarely you can find parasites in the blood. So this is why we tend to go into the reticuloendothelial tissue of like spleen, lymph nodes, and bone marrow. Commonly in the Sudan, in Khartoum, we used to do bone marrow or lymph nodes. Okay, Sudan is very high up on the research of Leishmaniasis, very high up. And if you read the literature, which I have been reading since the last week, I could see that many references is to the Sudan, because the disease is not only prevalent in South Sudan, in Malakal, in Gadarif area, in the borders with Ethiopia, in the Mazin area. And there is a very interesting story about migrating. You remember we called migrant medicine. Migrant medicine is not medicine which is taken from here to Europe. It could be from one locality in the Sudan to the other. And Professor Ahmed team has shown that there is outbreak of visceral leishmaniasis in Baba Nusa. Okay, in Baba Nusa. Okay, this is north, and because the tribes, the Rizegat tribes, which herd the camels and the horses, they go south into the south of Sudan to Bantu, where they can find a greener pasture and water for their animals. Okay, and when they come back after a few months, they get ill with a chronic fever, which turned out to be visceral leishmaniasis. So this tribal movement has brought, okay, not only the Kala-Azar, but also the fly, because the fly can hang on to a human being or to a luggage, and then being brought to Baba Nusa. So this is migrant disease, and it was being well described by Professor Ahmed Team and Hashim Warsa Maghali. So the research of Sudan is very high up. Okay, in all the literature, you say, well, pentastam is so and so and so. In the Sudan, it is so and so and so. Okay, the test of that test has a sensitivity in the world so and so, but in Sudan it has another sensitivity of so and so. We are extremely proud. Myself is extremely proud by the researchers who have done by Sudanese. I would like to pay tribute to those who helped in the research of Leishmaniasis from time very early, 1925, 30, by Kirk. Kirk is a British doctor, a pathologist, and he wrote quite a bit about visceral leishmaniasis, followed by Muhammad Hamid Sati. Okay, he's, I think, a parasitologist or a public health expert. He also described a lot of diseases. But then came the giant of research, the giant of science, who is Professor Ahmed Muhammad Al-Hassan. This man has been honored by the Royal Society of Medicine in Britain for his work in Kalazar, and they devoted a complete session in their meeting, and they devoted a special supplement of the Royal Society journal to his papers. So there is now a supplement, complete supplement, written by Professor Ahmed and his group on Kalazar in the Sudan. So, and UMST, University of Medical Science and Technology, has honored this man in 1996 when it named one of the lecture theaters under his name. I would like also to pay tribute to Professor Hashim Warsa Maghalib. He is a tropical immunologist who has really contributed a lot to research in immunological research in visceral leishmaniasis, and also to Professor Muhammad Siddiq, a clinician who had an MD on visceral leishmaniasis. As far as treatment is concerned, if you treat patients, then there is reservoir will get less. If you know the reservoir and you combat the reservoir, then the disease will be less. And then the vector. The vector has to be targeted. This is why I describe the vector as lazy, cannot fly, and so on, so because this is important in combating or eradicating the vector. Okay, if you know what is the habits of the vector, then you can design ways of eliminating the vector. Unlike the vector Simulium damnosum, which is called black fly of Onchocerciasis, this one travels 500 kilometers away. So, but here, this vector, which is lazy, you can target it very easily in where it is abundant. So that is important, but it requires a lot of dedication, a lot of money, okay, in combating that vector, which is a really bad vector, can fly, and it is called phlebotomous papatasy. Okay, as we have about 5 minutes more, I would just like to highlight the number of cases which comes to the hospitals. I visited the Darif area. I found almost 65% at the time when I visited about Kalazar. There is a huge war called Kalazar, okay? And in Malakal, I visited Malakal also. There were a huge war called Kalazar. And in Sinja, which is near the Mazin, Sinnar area. Again, there is a lot of Kalazar there. In Baba Nusa, which is in western Sudan, again, there is Kalazar there. Apart from the south is full of Kalazar. So this is a disease which needs more investigation and more treatment. So it's important that you will learn something about visceral leishmaniasis and the other forms of leishmaniasis. So it's the dermal leishmaniasis, is caused by Leishmania tropica. Leishmania tropica, and it's either in a small nodules, okay, itchy at the start. The nodule will be big, and then the itch will go, and then this will grow and may ulcerate. This is why you'll have a lot of ulcers. If you have an ulcer which is not healing for a couple of weeks, then you have to think of dermal leishmaniasis. And there was a break in Khartoum in the 80s about dermal. Everybody almost had visceral dermal leishmaniasis. So it's open. The ulcer it has a lid or the edge, okay, and the edge is turned in, okay, and it is very easy to smear the edge for the parasite. It can easily be diagnosed by that. Dermal leishmaniasis is a spontaneous cure. A spontaneous cure. So if you leave for months, 3 months, then it can disappear, but it disappears with the scar. Pentustam is again a drug of choice if you need a rapid healing of the lesions, and you can use pentustam or the other drugs which have been mentioned earlier. Okay, so it's a disease which is disfiguring, but it has no constitutional symptoms to go with it. So that is, I think, what I had for today. But just to remind you that the vector is an important transmitter of disease, and it's not a mechanical vector. It's a vector that develops the parasite. We have a mechanical vector like housefly. The housefly is a mechanical vector. If it sits on the feces, it picks up parasite like Entamoeba histolytica, okay, and then bring it to the food. That is mechanical. It takes it by legs and then drops it in the food, and then you get the Entamoeba histolytica when you eat the food, okay? But here, the vector is an active vector. It develops the parasite, as we said. It takes it as amezygoids, okay, amezygoids, and then promastigoids develop inside the vector, and then it injected as promastigoids, and then it turns into amastigoids and comes back into amastigoids for more development in the vector, and the cycle will continue. So this is an active vector. And when we talk about tropical diseases, very important that you should know the vector, because one of the nowadays areas of attacking the cycle is by killing the vector, insecticiding the area of the vector, okay, heavily, so that the vector, if it is decreased, then it's the disease disappears. And people have shown it with malaria, okay, when they attack the malaria very well, it's being treated. Leishmaniasis has a vector, which is mosquitoes, and in some of the Southeast Asian islands, lymphatic filariasis has been eliminated because the vector has been eliminated. So these are the areas which you would like to think and read about. Okay, the next case will be delivered to you by today, and if you kindly look into the case, try to solve it. Okay, and you are free. Okay, whatever you do, if you want to attend or if you want to participate, I think I'll tell you the best way, which is taking part, active part in solving the problem. Then you will make benefit from the lecture here. Are there any questions? Any questions?
No, thank you so much. يعطيك العافية Prof.
It's very clear. Clear. Ruba.
Yes, everything is clear.
It's
It was
clear.
a very
Okay.
productive lecture.
Okay, thank you very much indeed. And please remember and pay tribute to the pioneers, the Sudanese pioneers of research in visceral leishmaniasis. I would like to thank you very much for joining me to this lecture, and we hope at the end we put these lectures together, maybe in audio form or written form, that we can use it for the future. We never know if this time next year we'll be here or not. Thank you very much indeed. Bye.
Thank you.
Okay.